Hello, good evening, everyone. Thank you all very much for joining us. Apologies for the slightly delayed start to this event. My name is Ed Harding. It's a real privilege to be a chair of this discussion. I am the Managing Director of the Health Policy Partnership, an international health policy consultancy based here in London, and the Network Director of the Heart Failure Policy Network. Very briefly, if you haven't heard of us, we are a pan-European network of patients, clinicians, and other key stakeholders working to advance meaningful policy changes in heart failure. It's been a huge pleasure to work with the British Society of Heart Failure in setting up this event, and a real privilege to be part of any event to support the heart failure community here in the UK. But before we go any further, a huge thanks to you all for making time to join us. I am distinctly aware of the pressures under which many of you, our colleagues, may be facing at the moment, and it's certainly no small sacrifice to give us an hour of your time. So our deep thanks and respect to you all, as well as to anyone on this call who, of course, is living with heart failure and is finding their way through the enormous disruptions of the last year. It's incredibly encouraging to see the very high participation in this event, and I think we have a really important discussion to come. Very briefly, it's my job to set some of the scene relatively quickly. So let us all remember that in talking about heart failure, we are also talking about the #1 cause of hospital admissions in the UK, and certainly across Europe, the #1 cause of preventable hospital admissions, which is an important fact. Furthermore, it's also one of the fastest growing causes of admissions, having risen 3 times faster than other similar causes over the last 5-year period, a trend which can only, of course, be accelerated by the disruptions and the inevitable mechanisms of the COVID-19 pandemic. Of course, broadly, overall in heart failure, we see huge potential for improvement and for effective disease management. But as we all know, too often, we know what to do, but often we don't necessarily do it. We also have a very important human prerogative in how difficult heart failure can be to live with, and the difference that very effective person-centered and integrated support can make to all of us. As we probably know, 1 in 5 of us will at some point live with heart failure. So we indeed are talking about our own futures, as well as the futures of those that we love and care for as well. Naturally, we are coming to discussion at a time of very considerable change, and nor can we cover all of the incredible backstory of heart failure, care services and policy in England, nor answer all of the questions going forward. But I do think we have a really important job to do tonight in activating and discussing with all of us the changes that are going on within England at the regional level and how we could move forward. So let's just briefly recap on what we're trying to do tonight. While there are no easy solutions, we hope to have an insightful discussion as to how our HF clinical advocacy leaders could better understand and engage with the new NHS structures, the rationale for leadership by HF specialists and healthcare professionals with expertise in HF and across CVD and chronic disease more widely. And ultimately, we hope to inspire you or those who know to apply for positions in the new cardiac networks now and at some point in the future. On that note, let's get started. We have a list of incredibly distinguished speakers who will be introducing properly in due course. But as you will see here, we have Professor Nick Linker from NHS England, Dr. Simon Williams from the VSH, Dr. Hugh McIntyre in his role as chair at NICE, and Dr. Sonia Babu-Narayan from the British Heart Foundation. So hugely looking forward to this very important discussion. And without any further ado, let me pass over to Professor Nick Linker.
Great, thanks very much, Ed, for that introduction. I will just share my screen. Which will hopefully work. Thank you. So I've been asked to give an update on the status of the long-term plan and also to outline some of the developments that we are implementing with regards to the restoration or re-establishment of cardiac networks. It is fair to say that the long-term plan has a commitment in terms of the early diagnosis and improved management of heart failure, and that commitment remains. despite the impact of COVID during the last year or so, and we have not changed the direction or our targets in terms of the long-term plan. The ambition in terms of heart failure is that we will improve the diagnosis by diagnosing an additional 54,000 people with heart failure. Furthermore, we will aim to improve 30-day mortality and also reduce hospital admissions. In particular, we will increase the access of patients with heart failure to cardiac rehabilitation. We are aware at the moment that only 10% of patients with heart failure have access to cardiac rehabilitation, and our ambition is within the time frame of the long-term plan to increase that to 33%. In terms of criteria that we are using to monitor our success, we are very much aware that in terms of improving the diagnosis, we need to expand the workforce, particularly around cardiac physiologists, but also around heart failure specialist nurses. We are also keen to reduce unwarranted variation in care across the country and within a network and within regions for patients admitted to hospital with heart failure or heart valve disease. In terms of our work programs, we are looking into developing particular work streams. So we are developing an e-learning for health heart failure toolkit. It doesn't particularly surprise me, although it is disappointing, about how many people, not only in the public, but also who are medical professionals, do not really understand what heart failure is. And therefore, we have already launched the first part of an e-learning for health toolkit to educate all healthcare professionals in terms of the diagnosis and management of heart failure. We are working with the diagnostics team to improve access for diagnostics within community diagnostic hubs for patients with heart failure. We are developing a managing heart failure at home support package. This is a digital package currently piloted in 5 GP practices around the country to enable patients to remotely monitor and manage their heart failure through digital technology, but also through increased input from heart failure community services to help them improve their quality of life and reduce the need for hospital admissions. Furthermore, we are also going to have elements of heart failure included in the PCN Directed Enhanced Service contract, which I'll mention in a minute. So what tools are we supplying at the moment in terms of facilitating support for heart failure? So prior to April of last year, the quality and outcomes framework in primary care was to diagnose patients with heart failure within 12 months of entering on the heart failure register. However, you also had a 3-month window to actually get on the heart failure registry, in which case there was therefore a 15-month window to diagnose heart failure. That is clearly too long. We have reduced that to 6 months and added a requirement for an annual functional capacity and medication review. Although it will be challenging, I will be keen to monitor this with a review to reducing the time frame even further going forward. Many patients do not present with heart failure, they present with breathlessness. And therefore, we have established a breathlessness work stream working with Andrew Menzies-Gow, who is the National Clinical Director for Respiratory Disease. And this is linked into the Community Diagnostic Hubs work so that we can have a better way of triaging and performing diagnostic tests on people who present with breathlessness so they can be more efficiently diagnosed and triaged into the appropriate pathway, be it management of their lung disease or management of their heart failure, and then they can be signposted to the appropriate specialist for their management. In addition to this, we will also be considering the workforce implications in order to deliver this. As you know, there are challenges in diagnosing heart failure, and one of the important areas is that NT-proBNP testing can help address this. It is our ambition to increase the access to this across the country. We are running pilot funding to support local systems to develop on commitments set out in the plan to diagnose heart failure. Particularly, we are looking to reduce health inequalities in this area, so projects that are focusing on health inequality, we would be very keen to support. And lastly, as I mentioned, we will be in developing the PCN Directed Enhanced Service for CVD prevention to also include heart failure diagnosis and management. And this is going to be published in October of this year. The final part of my presentation relates to how we are going to implement what is currently called the Cardiac Pathway Improvement Programme. This is a programme bringing together different aspects of work across NHS England and Improvement to promote better cardiac health. The aims are in line with the long-term plan to reduce mortality, reduce waits, better care, and more sustainable costs of care. A key part of this programme is the development of cardiac networks to drive and support the local delivery of these objectives. And these are already being established and have been directed to the regional teams last month. So in terms of what our vision is, those of you who are old enough, like myself, may remember that in the early 2000s, we had cardiac networks. However, these were mainly focused around secondary and tertiary care. And that is not what we are planning this time. We are looking at a whole pathway approach. So we are starting with CVD prevention in terms of managing risk factors for patients. We are looking at primary and community services in terms of detection and then diagnosis of patients. We are looking at secondary and tertiary care management, including, for example, cardiac surgery as well, and then primary care, rehabilitation, and end-of-life care. We are going to focus on high-impact changes, but we are integrating the long-term plan aims, the recommendations from the GIRF reports, specialised commissioning service specifications, outpatient transformation and development, and the number of systems that the NHS has, but we're going to bring all of these together through a network-based approach to have a single way of delivering standardised end-to-end pathways. Now, although the pathways are going to be standardised, it's also important that the community and primary care end are customised to take into account the variation in the population with ethnic minorities and with health inequalities, but that the pathway from when the patient enters it is standardised. So what are we going to be doing? We are providing, as I've already said, the whole range of services from prevention through to tertiary care. These will be delivered by a number of networks. This is likely to be 14 at the moment, and you will see there are a variety across the country in terms of numbers. It is really important that these networks have input from primary care, from patients, from our third sector partners. It's really important that these are not just driven by secondary and tertiary care. That is really important. It's also important that these networks partnership with or on behalf of constituent ICSs. All of our networks will be expected to contain or be very closely allied to a tertiary centre because of the nature of our pathways. Now, that's not always going to be within a single ICS. It may be in certain parts of the country, but it may be a multi-ICS footprint in other parts of the country. There will be deliverables for these networks. There will be a specification that will be delivered that the networks will need to adhere to, and they will be accountable. This just gives you a very quick overview of the work streams and the amount of work that is going into developing these networks. This is a very complicated slide, and I'm not really going to talk through it at all, except to point out the complexities that we need to cover for this. This is not going to be easy. It will be hard work, but you will see within there are elements throughout the work streams from both the public through to outpatients, acute treatment, and community services where heart failure is highlighted. From increasing focus on secondary care prevention through to supported self-management through NHS at home and increase into rehab. It's really important that cross-cutting themes, including digital innovation are also adopted in order to help us deliver this. So finally, moving forward, the network specification is in development, and we expect this to be published later this month. Networks will be clinically led, and they will be accountable to their regional teams and also to the national teams. Again, recurring funding has been allocated to the teams, and this is guaranteed for the next 3 to 5 years. And therefore, this will support the appointment of clinical leads and network structures. Regions are developing detailed plans related to the network structure in their area, and we've already had meetings with each of the regions to start work on how to develop this. So the difference is these are properly funded, they're working across whole pathways, and they will be accountable for delivering the ambitions of the long-term plan and GIRF, etc. And we look forward to continuing to work in this area with our partners, such as BSH, BHF, and the Heart Failure Policy Network, to ensure that these networks are the drivers of change. Thank you very much.
Thank you very much, Professor Linker, for that overview of national policy, the ambition around the care pathways, and the role of cardiac networks in helping to bring this to life in a much broader and multidisciplinary way than ever before. I believe that we'll be able to share your slides later for colleagues who would like to revisit the detail themselves. Thank you very much. A quick reminder that delegates are very welcome to submit questions through the Q&A for the discussion section later. So if you do have any questions ready to hand, please go for it, and we will be asking them later. So it's a huge pleasure to move on to our next speaker, Dr. Simon Williams, who is chair of the British Society of Heart Failure and also consultant cardiologist and clinical lead for heart failure at Wythenshawe Hospital, Manchester, as well as being a senior lecturer at the University of Manchester and an expert advisory group member of the NHS long-term plan, heart failure and heart valve. Over to you, Dr. Williams.
Thanks, Ed. I'd just like to, before I start giving my presentation, thank everybody this evening, Heart Failure Policy Network, NHS England, British Heart Foundation, all the patient groups, all the other charities that have been involved in putting together this webinar. I think it's very important that we all work together. And as you've heard from Nick, things are changing. It's important that we all communicate with each other. And I echo what Nick is saying, that it should be across primary, secondary and tertiary care, involving patients, involving innovations such as digital health. And I'm here tonight really to tell you the role for heart failure specialists within those new structures. So next slide, please. Heart failure is a big problem. In the UK, there are nearly 1 million people with heart failure, and there are 200,000 new cases diagnosed per year. And that's actually more than new cancers, of the commonest 4 cancers. So heart failure is a really, really big problem. And we also know that heart failure is a very big success story. So I can remember at medical school over 30 years ago, there was a trial called the Consensus trial published, which showed that enalapril made patients with heart failure live longer. And over the past 30 years, we've had lots and lots of trials and treatments, not just pharmacological therapies, but device therapies that enable our patients to live well and better with heart failure. So ACE inhibitors, ARBs, beta blockers, MRAs, sinus node blockers such as ivabradine, through to newer drugs, cubitril valsartan, and the SGLT2 inhibitors. In conjunction with device therapy, defibrillators, CRTs, it really is a success story of modern medicine, not just in cardiology. And it's therefore important, and it's our duty of care as heart failure specialists to allow our patients to be given these life-saving treatments. And it's really important to identify heart failure early. And Nick has talked about various schemes, including the long-term plan and pilot programs in the UK to allow early diagnosis with access to N-terminal pro-BNP, which will accelerate the diagnosis of heart failure, allow referral to a specialist, and allow the specialist to work with the patient to get people on the right therapies, giving patients the freedom to live well and with the condition. Next slide, please. And over the past few years, the BSH has been working with other major cardiovascular charities to allow us to recognise heart failure as a national priority. And we need leadership from this. And heart failure is a really good example of a chronic condition that is multi-morbid. Patients often have other cardiac conditions, atrial fibrillation, ischemic heart disease, hypertension, heart valve disease, chronic kidney disease, diabetes. And as a heart failure specialist, we are used to managing and balancing all those conditions. So heart failure really is an exemplar for the treatment of other longer term conditions. So at the BSH, we've tried to provide leadership in this and looking at data, and we've got lots of data in heart failure, not just from the trial data, but we have huge registry sets of data. So the National Heart Failure Audit, which has been running for over 10 years, is envied worldwide, really, which gives a snapshot of what's happening to our patients when they get admitted to hospital. And also, we've had lots of data during the pandemic to show us what is happening, not just with heart failure, but with other cardiovascular diseases. And it's important that we look at this data in order to shape our future strategies to make heart failure a national priority. However, we've not been very good at putting patients at the forefront of these strategies. And I think we are realizing this as healthcare professionals and professional societies, that we need more patient input. And I'm delighted to say that over the past few months, the BSH has formed a patient advisory panel, and we are working with our patients in the advisory panel to look at shaping the strategies in the longer term. Next slide, please. And it's important that we get involved. Nick has already told you that the structures in the NHS are changing. There are going to be integrated care services. They are going to be cardiac networks within each region. So it's important that we as leaders in heart failure provide expertise to the network board to put heart failure on those boards' agenda. We need competency in each regional structure to plan the care and make sure heart failure is diagnosed early and make sure every patient with heart failure has access to a specialist and also the good treatments that have been shown to be of benefit over the past 30 years. I've already told you that heart failure is a complex syndrome. It's multifactorial, and heart failure specialists are very good at managing those comorbidities. It should be patient-centered. Every heart failure patient should have individualized care, and we at the BSH have been at the forefront of trying to address individualized care, and also liaise with not just your heart failure specialists, if you're a patient, to get the right treatments, but rehabilitation, palliative care. It really should have a holistic care approach. And heart failure is secondary to most other cardiac conditions, ischemic heart disease, heart attacks, hypertension, valve disease, arrhythmias, and therefore a broad knowledge base is required. So it's very important that in the changing structures of the NHS, heart failure specialists make themselves known in order to work with other specialists to try and provide a joined up service and a seamless service from primary into secondary into tertiary care. Next slide, please. There are key barriers to tackle. We have seen over the past 10 years that the media tend to focus on heart attacks and strokes. Symptoms of heart failure are not communicated by the media. The public are not really aware of the symptoms of heart failure. And there is a perception, not just amongst the patients or the media, but amongst the medical community, that heart failure is not a medical emergency. And we need to change that. We need to have early diagnosis, because we know that early diagnosis leads to specialist referral, which leads to good treatment, which leads to better outcomes. I think the public are also a little bit worried about overburdening the NHS. They're worried about the pandemic. And we've seen in the pandemic, there has been a massive health inequality and a massive gap in especially minority group engagements. And that is not only true of COVID and the vaccination program, but also other cardiovascular conditions. There's been a reduction across all cardiovascular conditions in the pandemic, with admission to hospital and patients accessing healthcare. And as a result of that, we've missed cases of heart failure, and this will lead to an increased morbidity and mortality. And what we are seeing is that many heart failure cases are now diagnosed as patients leave it late because they don't want to worry their healthcare professionals, and they often present into hospital. So there is a widespread lack of awareness of the symptoms with heart failure, and heart failure is one of the biggest societal health issues in the UK. Next slide, please. So my plea to all you guys out there, all you healthcare professionals and patients out there watching this webinar, is that we need to get involved. We need to get involved with the new NHS structures. We need to give some advice to the new cardiac boards and the new cardiac network, because heart failure is a chronic disease. We as healthcare professionals will look after our patients for many years. Our patients have a lot of comorbidities, and heart failure, the prevalence is increasing. We have nearly 1 million people with heart failure in the UK, and I'm sure in 5 years that figure will be a lot higher. So we have a real opportunity here to come up with solutions, to work with our colleagues across each region to provide better heart failure care. So seek out and apply for opportunities, get involved, see who is leading your networks, see who is involved in the networks, because as Nick said, these will become a good thing in the future to join up the care. Next slide, please. So before I finish, it would be remiss of me not to mention the new BSH public awareness campaign, the F word, which was launched at the weekend. This coincides with the European Heart Failure Awareness Week, but we envisage this campaign not just lasting a week, but over the next few years. We would like the public to be more aware of the symptoms with heart failure so they can present earlier to healthcare professionals. And the F word centres around freedom from heart failure symptoms, and the symptoms, of course, are fighting for breath, fatigue, and filling up with fluid. Next slide, please. And I'm delighted to report that we have Brian Blessed on board as a heart failure ambassador. And as we launched the campaign on Saturday, I was pleased to say that over 200 media outlets picked up on this. Brian Blessed is no stranger to using the F word, and therefore it really, really does back the campaign very well. So fighting for breath, fatigue, and filling up with fluid. So please visit our website to see what we're up to in terms of the F word and spread the word. So thank you very much.
Thank you very much, Dr. Williams, for that a comprehensive call to the whole of the heart failure community to get involved, I think, which really kicks off our discussion and the next two speakers. So with that in mind, it's a great pleasure to introduce Dr. Hugh McIntyre, who is a consultant physician and independent clinician to the West Sussex CCG governing body, and also a Sussex ICS steering group member, and also chair of the NICE Quality Standards Committee and a medical advisor to the NICE board. Dr. McIntyre, would be fantastic to hear your views on how efforts in heart failure and the new cardiac networks can fit into the broader strategic objectives for cardiovascular care.
Thank you very much indeed. Good evening, everyone, and thank you very much for inviting me along. I've got 5 minutes, a short time, to give you a different angle, a broader perspective. I have looked after heart failure in the south coast of England with a team of excellent nurses, both in hospital and community, for over 20 years. And the view I want to give you integrates that with my experience working with the CCG and on the steering group of the Sussex Integrated Care System. And also a lot of work with NICE, including the heart failure guideline back 10 years ago, over 10 years ago now. 3 areas I'm going to cover. The first, integrated care systems, we've heard mentioned, the world post-COVID, and what this means for heart failure care. I will draw out a few key words as we go along, because I'm not coming from a health policy angle. I'm not coming from an official heart failure organisation angle. I'm coming from a view, if you like, from the ground up. And I think what we've heard so far is fascinating and welcome, because in my experience of working with patients through the nurses and the community, there is a reality to heart failure, which hitherto I think has been missed in their care about their environment, their own home environment, and the sort of needs they have. And our experience is fulfilling those is as important as anything else. So next slide, please. This is just a little crash course in integrated care systems, but the point of this is anyone involved with heart failure in this new environment needs to understand this. There are 3 layers. At the top of the layer, the overarching organisation is an integrated care system. This replaces CCGs. Commissioning has gone. Functionally, they'll still be commissioning at an ICS level, but it will be different. It's much more about partnership working. And these integrated care systems start in shadow form later this year and will become law and take over all of the legal duties of CCGs next April. The ICSs, these integrated care systems, are, if you like, the vehicle to deliver the long-term plan. And if I were to put that down to a few words, and I'm sorry to use bold, but in a way there's a theme that I will pick out as we go along. It's about integration, and that's health and social care, but vertically, so primary and secondary care. It's about partnership. You will hear about partnership boards and integrated partnership pathways and so on, integrated care partnerships. And that's across what will be referred to as providers. And it's important to see that a provider is not just the hospital, secondary or tertiary, it is primary care, it is the community, it is mental health, it is voluntary organisations. We've heard that, but the provider is not just the hospital. This is anything but hospital-centric. And the key words in the long-term plan are population, person and prevention, with outcomes to deliver particularly prevention. The way it works below the ICS level is at place. I'll come back to that in a second. And that primary care networks, these are, if you like, collaboratives of current GP practices of between 30 and 50,000 patients. And these will be the granular locality group that drives the care delivered, if you like, in your area. And what place will be is the intermediary level, probably a sort of operating unit, if you like, which will sit on the existing footprint of the CCG. And that will be where a lot of the care partnerships will be coordinated round localities. So you've got to envisage a wider angle from the ICS and then coming down through place to the individual PCNs to start to address some of the issues we've heard. Next slide, please. That's the theory. Just let me ground this in a reality check. We've heard about COVID mentioned by a couple of speakers. And I first want to talk about the system impact, because we've all been affected by this. And if we can look for positives, we can find them. There has been some exceptional working, not just by individual human beings, but through partnership between health and social care, between what health does and care homes, for example. We've heard a bit about digital and innovation. We're all aware of, here we are on Zoom and so on. And the speed at which things have happened, such as guidance, has been remarkable. And a lot of the aspiration going forward is to embed that. So if you like, at a system level, COVID has sort of been an accelerator for the ICSs in a way of working, and therefore for the delivery of the long-term plan, which weaves in completely and consistently with everything we've heard from Prof. Linker. But it's important for those involved in heart failure to realise that this isn't just cardiovascular. What the CCG that I'm involved with has on its risk register is cancer weights. That is a real problem. There are people presenting late with cancer, elective waiting lists, mental health, in everyone, particularly children and young people. So also too within this, the human side, I won't go through this in detail, but it's worth remembering the context in which the NHS is going to operate in the next 18 months will be about burnout, will be about this recovery of all the waiting lists and so on. And finally, and the key point from COVID, is this issue in care homes about inequalities. What frames the whole of the NHS on the ground at the moment is inequalities. And through that, looking at population, person and prevention. So that's the two parts of the context. Final slide, please. So heart failure in this, I'm touching slightly on the next speaker's topic here as the exemplar, so I won't go into detail. But I think heart failure has to be seen as packaged within a wider possibly cardiometabolic bundle. What people need to hear at the ICS level and the CCG level is not just more specialist diabetes, kidney, heart failure nurses necessarily. It's about getting involved in the management of the heart failure on the ground. Heart failure can't be fixed, it's managed, and self-care is a dominant theme that emerges. If I make one semi-political comment, I think that the heart failure organisation itself and clinicians need to grasp PEF and social determinants now to make this work, because that is what's real on the ground. And so my final point is this. With regards to the sort of leaders that might be involved, it isn't where you work, the hospital you're in. It's actually what matters to the individual person, to the community. We've heard it's about the whole pathway of care. These aren't words. It starts outside with what the individual person with the experience and burden of heart failure symptoms is suffering. And that is a new way of thinking. And to deliver this properly, that needs to be taken on board. And if it's to work, whoever leads a network and whoever delivers heart failure care needs to come with an attitude that they're going to make something better for the system and for the individual person. Thank you very much indeed.
Thank you very much, Dr. McIntyre, for that reflection, born from personal experience and systemic realities on I think, some of the bravery that we are signing up to in the ICS system and what that actually means. So much appreciated. It's a great pleasure then to introduce our next speaker, Dr. Sonia Babunarian, who is an associate medical director at the British Heart Foundation. Dr. Babunarian also is has primary responsibility within the British Heart Foundation for clinical studies and fellowships, and she's a reader in adult congenital heart disease, the National Heart and Lung Institute, Imperial College London, as well as being an honorary consultant cardiologist at the Royal Brompton Hospital, London, and many other things as well. Dr. Babunarian, it'd be fantastic if you could give us your view on how do we make sure the improvements in heart failure deliver on some of the broader visions that have been set out by the British Heart Foundation, and how do we fit this into the context of building back better? How could heart failure act as a societal exemplar, if you will, for action on other chronic diseases?
Thank you. I will discuss the impact of the COVID-19 pandemic more broadly on people with cardiovascular diseases, including those with heart failure. It's been really significant in this first year of the pandemic. The NHS has been incredible. Many of us here are part of that. Emergency care stayed open throughout for everyone in the peak of COVID-19 surges and for everyone who needed it, COVID or not. And that wasn't possible throughout the world. Nevertheless, despite the unwavering efforts of the NHS, we know that heart patients have faced delays at every stage of their care on a scale never before. And this widespread disruption to care has likely contributed to over 5,800 extra deaths from heart and circulatory diseases. We know the impacts on services have been immense. We can count some things. There are 131,000 fewer catheter interventions or operations. There's been a 180-fold increase in people waiting more than a year for those sorts of procedures on waiting lists. But that kind of reduced delivery of intervention and surgery or increased waiting time doesn't really give us the whole picture. We've all just talked about early diagnosis being fundamental at the start of the heart disease pathway. We want to avoid delayed diagnosis, instill treatment early to improve outcomes for patients. During the pandemic, there were other changes. There was a steep and sustained drop in GP referral to cardiology, in diagnostic tests such as echocardiogram delivered. If we don't have an echocardiogram, we don't necessarily know that you have heart failure or that your heart failure is worsened. We're not optimizing your care. It's been a dramatic reduction in prescriptions for heart medications. These could be for optimization, not only prevention. Redeployment of heart failure nurses who provided services in the community and rehabilitation has meant some services were not available in the country. More people died at home. For many of us who are thinking about what we would want for ourselves, that could be desirable, but we don't know how many families and carers felt really unsupported in terms of planning end-of-life care and end-of-life support at home. So the unseen effects have been vast. This challenge ahead for services is significant, but it's not insurmountable. We're all in this together. We can all help. If services are supported to build back better, instead of switching back, just simply switching back on, we can really improve from even what we had before. In my view, it's not just building back better, It's building back better, bigger, and fairer. We've already heard about the health inequalities that have been so accelerated and amplified because of the pandemic. The emergence of the cardiac networks that we've heard about today and new ways of system working offer the opportunity to better join up services and reduce variation in care, good for everyone, not only for heart failure, but for the broader cardiovascular disease services and as an exemplar to other long-term conditions. Remarkable innovations by frontline NHS staff were catalyzed by COVID-19, and these new ways of working that enable efficiency and better outcomes, including better patient experience, those that don't exacerbate inequality will be here to stay as part of the healthcare menu. So I think there is a lot of hope and a lot that those of us who are here today together can do to contribute and to help. Last summer, the BHF worked with partners, including the British Society of Heart Failure, PCCS, BCS, and Pumping Marvellous, to publish our Heart Failure Blueprint for Change. It's a report informed by conversations also with heart failure services and patients, as well as the wider sector. Before COVID-19, we'd already heard from both patients and professionals that they still weren't receiving the care and support they needed for their heart failure, and there was significant variation across the nation. Care was often described as disjointed, and there were long-running issues about access to diagnostics in primary care, access to recovery, fair access to rehabilitation, or to MDT-led specialist care. So several recommendations for change emerged, including the devolution of decision-making and budgets to ICSs, that seems to be happening, and an increasing emphasis on systems working to address local unmet need. And already from Nick Linker, we've heard how we've made that starting now. The 4 pillars of the Blueprint for Change that we all came to were that there should be a focus on people, not structures. Several times people today have talked about treating an individual. So that means taking a full pathway approach to improving services instead of just focusing on one issue at a time. Reframing heart failure as a long-term condition. As we've heard, heart failure awareness is not as good as we'd like it to be amongst the public and even amongst clinicians. We need to drive change with data. So that means better collection and use of data and there was a call for leadership across the pathway. There are opportunities for those of you listening tonight to think about that and get engaged. Things are happening, things are moving both nationally and locally, just as everyone desired. So the cardiac networks that we've heard about and the other emerging structures across the health and care system offer a number of vehicles that are ideal for delivering these key and agreed ambitions of the Blueprint for Change. They'll offer the opportunity for driving the full pathway approach to heart failure from prevention and diagnosis right through to the end of life. And they've never been more needed. And they've never been a better exemplar of how these sorts of structures could help every kind of long-term condition. Our work previously showed the importance of strong leadership in joining up heart failure services across the pathway. These networks are perfectly placed to lead that joined up care from prevention to end of life for patients and improve outcomes and experience. And so they need leaders amongst you that will play that important role in raising the profile of heart failure and getting engaged to make these really work. There'll also be a great opportunity for better data sharing across these settings, and the combination of the clinical network and the data sharing will allow timely data analysis and timely addressing of gaps that are identified by data in our system. We may talk about this more later. With 98% of heart failure patients also living with at least one other condition, this broader system approach should also help clinicians and services better work together to address the broad needs of patients, both physical and psychological. Individuals will have different needs. Taking this data-led, full pathway approach to heart failure will not only improve outcomes for our patients, but it could also lead to the blueprint for heart failure being used for other long-term conditions. So where does that leave you and me? The NHS is about to enter another period of significant change. This raises opportunities to do things differently and fix historic problems in care. Cardiac networks and the new ICS structures represent important vehicles for driving improvement. But for real change to happen, it needs to be all of us in this together. It needs to be led by people with a real understanding of heart failure and the impact it has on patients, clinical leaders. You can use your expertise, experience, and passion for improving care and patients' experience to drive real improvements. Get involved, whether that's applying for a role in your local network, putting yourself forward to better represent heart failure on an emerging ICS structure, or working with partners like the British Society of Heart Failure or us in the BHF to drive improvements in your own services. The BHF's Health Insight team across the UK support regional systems to drive those improvements, and they're also great contact points for you around the country. In the coming years, the NHS is going to be characterised by change. So maybe put yourself forward, share your expertise, join in. This is a positive time for people living with heart failure and a positive time for healthcare professionals to get engaged. Change is coming, join in, get involved. You could help shape how the NHS will deliver on its ambitions for heart failure and ensure its success. Thank you.
Thank you very much, Sonia, for that view, I think, across the whole CVD community and specifically within heart failure as to what we can do and how we can use some of the levers as well from, as you mentioned, existing work for the British Heart Foundation in the form of the blueprint, I think, to communicate that societal case. So huge thanks to all our speakers. I'm pleased to say we have some time for questions, and we have had some questions raised by audience members who've been attending. So I'm going to use a liberty as the chair to blend some of these together. We have had some from community heart failure specialist nurses and from other colleagues asking a question as to how might specialist nurses also become involved in these, and might I broaden that to a bigger point on how, not evidently we will have colleagues who will achieve or have a place within the clinical network, but how more broadly does the healthcare professional community around them help to support them and take interest in these clinical networks to advance HF as well. Professor Linker, can I start with you, and then we'll bring this back to the rest of the panel?
Yeah, certainly, Ed, and thanks very much for the question. So it is really important that we have a diverse and inclusive group of people who are working within the cardiac networks at a leadership level. At the moment, we are still in the time of actually developing these networks, so they don't, with some exceptions, currently exist. Some of the networks are already in place because they're legacy networks which we've have hung over. The networks will, however, be directed via their comms teams to go out and reach to the community, to reach to staff at all levels, to try and encourage engagement and involvement with the network. However, we are leaving the structure of the networks and how they run to the individual regions and networks. It's not something that NHS England centrally will direct, but we are encouraging them to be diverse and inclusive in who they invite onto their structures.
Thank you. Would any of the other panelists like to take that question? Hugh, over to you.
Thanks. I think there's two things. We heard from Prof. Linker at the beginning about community diagnosis. We heard a sense of there being a greater effort to identify earlier in the community. And I think community heart failure nurses have a huge role to play there. If I were to be slightly disruptive, why shouldn't the network lead perhaps be a nurse consultant or even a therapist who's got experience in cardiac rehabilitation? I think if one starts asking questions like that, one starts getting a perspective on how one would approach it. The second bit, and I'll be brief, is the support for the nurses in the community and the practitioners in general is essential. And I think that is a role that all heart failure specialists need to take on board as part of their work. We do that virtually at the moment. But I think a fundamental role is that there is a network of support and permission and development for people out in the community, be they primary care, general practitioners or nurses. Thank you.
Thank you. Any other panel members like to take that one?
Yeah, I would echo both what Nick and you have just said, really. I think heart failure specialist nurses are the lifeblood of treatment of heart failure. They do all of the work, not most of the work, all of the work. And I think it's really important that people who are involved with the new cardiac networks come from a multidisciplinary team. In some areas across the UK, it's the heart failure nurses that actually lead the service, and therefore the heart failure nurses should be involved in the cardiac networks. It doesn't matter what healthcare professional you are, it needs to be diverse, it needs to be mixed, and people need to engage across primary, secondary and tertiary care, and often the nurses are the people that will lead the charge on this. So I would encourage all the nurses to talk to their cardiology colleagues across their regions and try and get involved with this.
If I could just come into that to both Simon and to Hugh to say, I have made it very clear and in no uncertain terms to the regions that that myself and NHS England do not expect that these networks will be composed entirely of secondary and tertiary centre cardiologists in their ivory towers. It has to be inclusive. It has to include primary care. It has to include other healthcare professionals. Heart failure nurses are absolutely perfectly suited to these roles. There is absolutely no reason why these networks need to be led by a tertiary centre interventional cardiologist. So I absolutely support that, and that's the message that has gone out.
Thank you, Professor Linker. Dr. Baron-Ariane.
I was just going to say that the BHF is rightly proud of heart failure nurses. You'll remember that the very start of heart failure nurses came from a BHF project, and we now see them as every day in the NHS and part of our service. Just to mention that there are BHF Health System Insight team staff who are based all over the UK and work very directly with heart failure services regionally and are supportive, and they're very well placed to also help you find the right people to drive change in your area, or to help you find the right connections, or be a place that you can feed into the system. We work closely with everyone and try to synergize and be helpful.
Thank you. At the risk of going slightly over time, I can't resist passing on a few further questions. I do apologise to anyone who has asked a question that we're not able to cover. I'm going to choose one that talks about influencing investment funding and release of monies. I'm actually going to broaden that to a question that if the clinical networks are working with ICSs, and if we recognise the, albeit political and local nature of these, what thoughts would our panelist colleagues have in terms of what are you getting into? What sort of essentially political local skills would you need in linking to the ICS, their boards, those that are on them, some of the political representation, for example, from MPs? Would that be an important skill, or at least an interest from HF and CVD colleagues who are getting involved and dealing with the scale of transformation that we're hearing? Would any of the panelists like to take that?
Nick, sorry, I didn't quite follow the question, but I think whoever leads the network will need to understand what the pressures are at the ICS level. In terms of an introduction through to ICS seniority, that shouldn't be an issue in and of itself, I don't think. I think I'm happy to pick some of this up offline. We've got a lot of questions, and perhaps we could look at answering some of them in a different way. But I do think approaching ICSs now, they're nascent, they're in development, but it must be to solve a problem, not to bring a problem. It must be, here's what we want to do in this disease area to make things better for your population and deal with inequalities. And if people went with that message, it will be received well as an ICS level, particularly if we're going to be asking GPs to be doing more diagnosis within the next 6 months with a DES, a direct enhanced service. So I think, I'm not sure if that completely answers the question, but I think the time is now for that kind of engagement.
Thank you. Also bringing a question here mentioned by an audience member about pump priming of new digital innovation to improve and integrate care. Professor Linker, do you have any comments from NHS England about funds that might support this, where HF or CVD interests could play in?
So yes, part of the drivers, as you saw in terms of the cross-cutting themes for networks, is the importance of digital technology for this, and we've seen that particularly during the COVID era. So we are working very closely with NHSX to improve access and develop digital tools to enable patients. Heart failure is a very good example of how patients with these digital tools can be able to monitor their conditions, are able to report to GPs. We are particularly looking at using NHSX. We have developed what they call a cardiology playbook of bringing all these various digital tools together. And also they are looking to try and incorporate these into single platforms, because as other speakers have mentioned, a lot of patients with heart failure will also have diabetes, atrial fibrillation, lung disease, and therefore having a single platform where they can access resources and apps for each of their conditions is something that we are developing with NHSX.
Thank you. Again, if everyone's happy to stay on a few more minutes, we do have quite a lot of questions. We won't carry on too much longer. I'm going to ask one here, and I quote, "From a junior clinician's perspective, many find it a huge challenge to step up from being a registrar to being a consultant, being asked to serve as a leader and to having to deal with finances, organisations and executive boards." Would anyone like to comment on the broader support for these wider leadership skills that might be implied by the scale of transformation described?
Well, I can certainly say a small point that leadership skills and management skills are incredibly important. And having just my own registrar has just been appointed as a consultant, and we were discussing about the differences between being a junior doctor and being a consultant. There are quite a lot of resources out there. So in particular, there is the Faculty of Medical Leadership and Management that is allied to the Royal Colleges, and that is something that you could certainly explore. They have associate fellowships in that society, and they have a lot of training and courses on how to improve leadership and management skills.
Fantastic. I'm sorry again to anyone who's asked questions that we haven't been able to cover. There have been a few requests for contact to the speakers. Please can I ask you to email the either us or the BSH individually, and we would obviously pursue that on a one-on-one basis. If you please mention who you are and your interests, I'm sure we could pass that along. And also requests for research and research analysis. Again, if you'd like to frame those to us separately, I'm sure we'd be glad to pass on any knowledge that we have. So I'm going to say an enormous thank you to all of you who have joined us as a herd at this critical moment, and absolutely, of course, to our speakers as well. I am conscious it is perhaps just the start of a broader journey or collaboration initiative on the part of the whole EHF community to make the very best of the clinical networks and the new ICS and regional systems. I'm conscious that we're over time, and once again I'll say an enormous thank you. I do hope to see you all again, and to be back in touch with news as how we might take this forward. In the meanwhile, let me just echo again the heartfelt calls that we have from our speakers to get involved, to be a part of this, whether it is you or a colleague who you know on the clinical networks, to take an active interest in this important function going forward. So once again, a huge thank you, and I wish you all a very good evening.